And welcome to the Paramedic AF show. I'm Daniel,
I'm Michelle.
and we have a special guest with us today. This is Luke Estes. He is the head of the MIH department for Prisma Health, which, for those of you who don't know, Prisma Health is the largest hospital system in the state of South Carolina. If I remember correctly, Luke, is it still that over half of the population is patients of Prisma?
It's pretty
Is that
close.
still
Yeah,
pretty
it's
close to it? Yeah. So we can disclose that Michelle and I used to work there. That is our main reason for knowing Luke. And we're very glad you're with us today.
Man, I appreciate it.
So I guess just for the people that don't know you, give us a little bit of just personal introduction. Tell us the highlights of your career, what got you to where you are now.
So I reside in Greenville, South Carolina. Got a wife, two boys, two dogs, a cat, and a turtle. So full house at the Estes residence. I originally came from the state of Missouri. So I was with Boone County Fire Protection District when I started my career. And then when I came to South Carolina, I met my wife, who was at the South End commander for Lexington EMS. And so we started dating, and I said, okay, it's time to go back to Missouri. And she said, I don't want to go to Missouri. And I said, okay, fine. I guess I'm living in South Carolina now. Um, but I was fortunate to have really good mentors from the state of Missouri, some good buddies like Alan Beard and some guys that I really looked up to as clinicians. And so when we started in South Carolina, I was at Richland County for a while. And then from Richland County, I went to up to Mission Health prior to their HCA purchase, and then back down to Prisma when the blood pilot was going on.
I'll say, I believe I first met you because you came to Prisma as a secondary training officer. You and Dan were running the department.
Correct.
That was back. Was that during COVID or was that right before?
Right, almost smack dab right before. I mean, it was kind of, we had a hinkling of COVID, and then it was full blown COVID.
And we all had to shave, and that was quite depressing.
Right. Yeah.
Daniel's a little scary without a beard and mustache.
Oh, he's seen. He's one of the few who's seen.
Yeah.
You can keep that memory.
So, tell people more what you do now. A little more about your role with MIH.
So, mobile integrated health, or some folks have it as community paramedicine. At Prisma Health, we have mobile integrated health, which is a umbrella. And under that umbrella, I manage that group or that team of about 20 community paramedics that are enterprise wide from upstate market to the Midlands market. And under that umbrella, we kind of divide off into silos. And those silos are specialty places of really community paramedicine, in which you find the right people who are passionate about a certain thing and they fit in that silo really well. You put that person in that silo, right? So we have a traditional community paramedic program, which is what everybody thinks about as a community paramedic program. It's going out, addressing social determinants of health. It's meeting people where they are. It's connecting them back to the healthcare. It's med reconciliation. It's disease education. All the things that everybody thinks about when they think about community paramedicine. And then because we're a healthcare system, we kind of have the ability to expand it a little bit. So we have a readmission program, which those community paramedics focus strictly on readmission, primarily in congestive heart failure for the hospital. And then we have a nursing home or a skilled nursing program we call it ETS, but it's Emergency Technicians Using Telehealth in Skilled Nursing Facilities. So ETS is much easier to say. But ETS is basically if you're a paramedic and you've gone to a nursing home or a skilled nursing facility for a call and gotten this isn't my patient, I just started, I don't work on this hall, I'm a traveler, all the excuses of not knowing what's going on, right? Instead of sending an ambulance, we send a community paramedic. And so that community paramedic walks in the door with the purpose of connecting them back to the geriatrician at the hospital and treating in place. The nice thing about the ETS program is that they're still highly trained and very clinical paramedics. and we carry everything the ambulance carries, majority, basically, generally, minus the ability to transport. And so if they walk in and it is a true 911 emergency, right, they just take off their community paramedic hat, put their paramedic hat on, call for a transport unit, and go to work. So there's real no delay in care because you're sending a high quality clinician there in the first place. And then other programs like our Hep C program meets people where they are who are diagnosed with hepatitis C. They enter the program. It's a grant funded program through a pharmaceutical company. They get the medication. That community paramedic follows them for 24 weeks, doing blood draws and follow-ups with our infectious disease doctors. And then they're viral load free at the end of 24 weeks. They are hepatitis C cured, right, using Eclipsa and Maverick in the field where they are, meeting them right there. So, then we just got all kinds of other stuff that we're doing. We're helping out the hospital with our PACE program. Our PACE participants are attributed lives to Prisma, so that means that Prisma is responsible for all of their care. So it makes sense for us to be trying to keep them healthy, to keep them out of the hospital, to keep them educated about their medication process, about their disease processes, and really just kind of a general Swiss Army knife of the Swiss Army knife, right? We're just another pair of scissors off that Swiss Army knife that operates kind of as a paramedic operates. You give us a problem and we'll go try to find a solution, and we'll do our darndest to get it.
When I worked for Prisma, I really enjoyed working, with you, with your teams and everything. And I think my first call that I ever had with you, actually, with one of your community medic patients, was it was called out as a 911 call for respiratory. And I think you had been listening to the radio and you heard the address go out and you recognized it. And it was, COPD exacerbation type stuff. And you came there and you're like, we're not going to the hospital. She's like, I need my meds. You're like, I got you. And it was so cool. It was so cool getting to see you there where, this patient literally just needed a breathing treatment and she assumed that she had to go to the hospital in order to get it. And you're like, I got you, boo boo. And you ended up like shooing us off in a respectful way, in a
Right.
respectful way. But, we got to help you and watch you and, do all the things and see that. And I also got to, brush elbows with some of the ETS providers. I always loved getting those 911 calls from some of the nursing homes, the SNF facilities, because we always got in our call notes that this was an ETS call. So I was like, okay, so what I am being given is actual accurate information. And, oftentimes it was, sepsis or something that the patient was so far gone, they were already getting antibiotics, but we did need to transport at that point. It wasn't just, oh, well, this is the start of a UTI or, something like that. I was wondering with the expansion of the buprenorphine program in the Oconee area, is community paramedicine doing a follow up with those patients once they're seen in the ER and then discharged for all of their follow up visits?
Yeah, so if you're familiar with Wes Wampler at all, but Wes
Mhm.
is our addiction medicine community paramedic. And so Wes actually works in addiction medicine. He reports to me. He's a community paramedic. He's a paramedic by trade, but he spends the majority of his time at the Addiction Medicine Center in Greenville under Dr. Litwin. And he's doing just like what you said. He's finding people who have not responded back to treatment, who have not responded back to Dr. Litwin or the Addiction Medicine Clinic. He's trying to find those patients where they are to just what's the barrier for you to get back to getting healthy or to get your medication to stay on track and all those good things. So yes, we are still we're using community paramedics to follow up with those patients. The majority of those fall on him from addiction medicine.
How have those statistics been going? I know at first it was like in the 30%. Has that increased with the use of the community paramedicine as well?
Yeah, so I our buprenorphine program currently, and I don't know if you're aware, but our buprenorphine program currently is on hold as we await a signature from the federal government. It's frustrating because yes, we had great results, and you're correct. It was around 30-40% of those folks that were receiving treatment were still in some sort of treatment 30 days post MAT. But we had a piece of paper that we needed to have signed for a special certificate or a special narcotic license in South Carolina, and South Carolina signed it, and we sent that to the federal government, and it's still floating around somewhere in Washington D.C. waiting for a signature. But it is unfortunate because we had really good results and positive outcomes out of that program, and I know that if we can get it off a pilot in the state of South Carolina and other EMS agencies start taking over or taking part in buprenorphine or any other MAT program, that results will be just amazing.
Now, before we kind of pick into the nitty gritties of this, what?
Sorry.
No, that's fine. Kind of give us a big picture view of the history of MIH, because I know for me, I would like hear that there were community paramedic programs like somewhere, but it was kind of nebulous what they were, what they did, and now it's kind of becoming more of a trend. So, what's the big picture history on that?
But some folks, if you just want to look at our program in 2019 started with Scott Gosnell, right, in Oconee County. The word, like you said, community paramedic was thrown out there. The Oconee staff said, yeah, we'd love to have a community paramedic. And Scott got off a truck and they put him in a QRV, and he said, what am I supposed to do? And they're like, we really don't know. Go figure it out. Like, do community paramedic stuff. And they're like, what's that? We don't know, So, Scott really started building foundations with getting relationships with folks in the Oconee County community and the Oconee County area, even in some Pickens area, just meeting with local nonprofits, meeting with service groups, meeting with nurse managers, and just saying, what is the need, because they did a community needs assessment, but really what I'm out here on the ground, what is the need? Where can we help? Right. And so Scott laid those foundations down for our department. What really was the catalyst for us to just explode was actual COVID. Right. And so when we had complete skilled nursing facilities calling the hospital and saying, we have one patient with COVID, we need to get rid of all of our patients. Right. Right. Or we need all of our patients to have COVID vaccines. We need, how are we going to do this? Because even to the skilled nursing facility, right? COVID was a new phenomenon, right? It was, we don't know what to do, so send everybody to the hospital. And as a hospital system, that won't work, right? And so they said, Luke, go forth and do something about this. We don't want them to come to the hospital, right? And so being paramedics, we were like, well, what can we do? Like, let's mask up. There at Prisma, we're fortunate to have those P100 masks. So we had really good respiratory protection and a cooler full of COVID vaccines. And we walked into the skilled nursing facility and said, let's start just vaccinating people, right? You got hallway 100, you got hallway 200, you got hallway 300, go forth and vaccinate. With the vaccine clinics, with our skilled nursing clinics, with people coming back to the hospital, with us responding out to scene calls with other paramedics and saying, yes, it may or may not be COVID, but the hospital ED is really not where you want to be, right? Because you will for sure get COVID there. So let's try to stay here. Let's try to manage our symptoms. Let's try to contact your primary care doctor, because everybody was kind of in this whirlwind of, I don't know what to do with COVID. Are you supposed to go to your doctor? Are you not supposed to go to your doctor? Like, it was this whirlwind. And so the paramedic or the community paramedic and some of our field staff too, the paramedics that were just on the 911 trucks, were really taking an active role in saying, you just need to sit here, right? You need to stay here and manage your symptoms here. And here's some over-the-counter stuff that you probably should look at. And, and then the community paramedic could take it a little farther and say, let's call your primary care doctor. Let's try to get you a prescription. I'll come back out and see you tomorrow if we need to, so we were kind of a small operation of about one person, 2019 up to about 2020. Right. And then COVID exploded and we became an operation of about 5 people. It's where they hired me on as the manager of mobile integrated health. And then we hired some more folks. And then we just continued to build upon all of these services that we provided. Like, we just, what do you need? What can a community paramedic fill for you? and that has grown to 20 community paramedics today.
Was it the kind of thing where you already had a passion built in for this and the opportunity presented itself, or were you just kind of thrust into it and then said, "Oh, I kind of like this. I want to keep doing it"?
Nah, so I had started, or I don't want to say I started, but I helped kind of build a program for another hospital system locally, prior to being at Prisma, and had really seen kind of the benefits of what meeting people where they were, or where they are, was would do to their health, to their just overall acceptance of healthcare, trust of healthcare, all of those things. And so I had a small little passion, and so when it was presented to me to become mobile integrated health manager, I was like, yes, this is something that I see the future of EMS becoming, right? And so I had a small passion, but then really just a absolute fire once I got to see what the healthcare system could help us accomplish.
So I don't mean to poke the bear, but this is something that we often hear on social media. I was actually told this by like way past instructor. When I had expressed interest in community paramedicine, back before it was so expansive with Prisma and everything else, some people have to say, just like, IFT is not the same as 911, a lot of people have to say that that community paramedics are not real paramedics. And I know my opinion, which is that is absolute horse stuff. But what do you, I guess, generally speaking, have to say to that, to the new providers that are coming into paramedicine that aren't sure if they want to do 911? Aren't sure if they want to do interfacility. This is a specific niche, especially with all the different, I think you said silos. Just there are so many different options. What would you say to a new provider coming in?
So I love that. I love the "you're not as good as me"
Mhm.
mentality from other paramedics. I directly challenge them to say that, I bet you don't see a 911 or an interfacility paramedic running iStats at the bedside. I
Mhm.
bet you don't see a
I wish we
911
did.
paramedic, yeah, running ultrasound at the bedside, replacing G tubes at the bedside, replacing trachs at the bedside, right? Yeah, I say that's kind of the response everybody has when it's trach time.
Sorry, lung butter
Yeah,
gets me.
yeah. But yes, there's a place for everyone. And I say to the person who wants to do 911, emergent 911, if that's your passion, then mobile integrated health is not your place, right? Because I mean, we're lit. We have sirens. We have lights. They come on when we stop on the roadside, right?
Mhm.
um,
Mhm.
that's about it. Uh, if you're looking for run an emergent to something, mobile integrated health isn't your thing.
Mhm.
But if you're looking to be clinical, if you're looking to be a clinician and a provider, and you're looking to, and I've always had this dream. You always had kind of, if you draw a line, right? Above the line is doctors and nurses. And then below the line, there was this big bubble, and it was called allied health, right? And that was paramedics and respiratory techs and speech therapy and PTOT and radiology techs and all of this stuff. And so it was, and maybe it's just me, but it was always just a line. And these folks were providers, and everybody else was allied health. Well, I can tell you now that the paramedic in the mobile integrated healthcare space for Prisma is standing on the line with providers and nursing, making peer-to-peer clinical decisions about what treatment plans should be, what treatment modalities should be. There is a number of times that the actual physician, says, "You're standing there looking at him. What do you think?" Right? Because we're doing this via telehealth, and so the physician will say, "You're standing there looking at him. What do you think?" And my paramedics will say, "I think we need to get a potassium. I think we should run a Chem 8 on him. I think we should maybe give him another breathing treatment. I think we should do this. I think we should," even outside of the paramedic scope, right? Because you're just not we doing outside of the paramedic scope, but you're standing there with a doctor and a nurse in a skilled nursing
Mhm.
facility going, that nurse has the ability to take orders, verbal orders from that physician. That
Mhm.
physician has the ability to give orders through the telehealth platform. And so
Mhm.
you can say, you know what? They were just post procedure 24 hours ago. Maybe we should give them 8011 ox, right? Not a paramedic skill in the state of South Carolina, not a drug that paramedics carry, but it's a thought. It's using your brain and saying, I want to be clinical and I want to look at this clinically, and just throwing it out there. And the physician may say, you know what, that's a great idea, or nope, we're already treating them for something like that, or,
Mhm.
whatever. But it's the ability to say, I'm clinical, I'm here, I'm helping make care decisions. To spin back around to your question, because your question was, what would I say to the new person who wants to be in mobile integrated health? I would say go get some experience if you don't have any experience, right? Because there is a difference in mobile integrated health. You don't have your partner to kind of bounce ideas off of. You're a single unit, right? You are talking to a physician in which you are their eyes, ears, hands, nose, everything to that physician. I mean, as nasty as it sounds, right? You're looking at a wound and you can say, this is what it looks like, this is what it feels like, this is what it smells like. Right? uh, you can give all of those things through the telehealth. So if you're new and you want to come to mobile integrated health and you have a passion for it, I say be clinical. Go get some 911 experience, get your critical care experience, however you want to get it, and then come see mobile integrated health. I want my providers to be clinicians. I ask them to be clinical. We put them through a ton of education at the hospital level that is sometimes, quite frankly, asinine, right? Because it's things that we already do,
Mhm.
right? I mean, so the hospital has its clinical education set up, and they have a pathway for everybody. Part of that pathway for the paramedics was a class on how to start IVs,
Mhm.
a class how to do IOs,
Yep.
and so the paramedic is going into that class probably could teach the class better than the instructor. But it's a check mark, it's a checkbox to meet the requirements of the healthcare system, to meet the requirements of what we demand of them. And so to the new person, find where you fit, but you got to have some experience before you come into us, into mobile integrated health.
Well, it's kind of funny because there's a number of people that work for you that I have worked with in the 911 setting prior to them coming to Prisma. What I usually say when people ask about this, because I've quite often told people, who feel stuck, I was like, hey, if you still want to do medicine, there's a good thing going on over at MIH at Prisma, or, wherever you want to do it. And I've noticed that, at least in my observation, a lot of the people that have come to you who used to do 911 are much happier. They seem to just feel much more fulfilled, and they seem to enjoy the medicine more. At least it's been my observation of it. Um,
Right.
and I
Right.
think I think you're right. I think that, get the experience doing heavy, emergent clinical stuff, because that is a crux of what you do. But, go get that experience, spin your wheels out for a little while, and then come into a place like this where you're using your head even more. Um,
Even more. Well, it's
yeah,
the
even
sick
more.
versus not sick. I
Yeah.
need you to be able to determine sick versus not sick very quickly.
Well, I think one of my favorite parts of working for Prisma, outside of how expansive the protocols were just for a normal street medic, is although the annual competencies, learning how to do IVs and intubation, IOs, and all that kind of stuff, like, yeah, I got redundant. I'm like, oh dear God, I know what I'm doing. But I think one of my favorite things that I learned is how to communicate with doctors, and not necessarily for the purpose of arguing, trying to tell the doctor that I'm right and you're wrong. Granted, that did happen sometimes. I had a doctor try and tell me the patient was having a STEMI even though troponin was 0, but that's not the point. I really enjoyed the way Prisma taught us how to communicate with all levels of staff: doctors, respiratory therapists, anesthesiologists, pharmacology, or excuse me, pharmacists, just literally everybody. And I can only imagine if I got to experience that as, just a 911 street medic at Prisma, then I have no doubt y'all do the additional training. And it is very fascinating be able to communicate with higher level medical providers to have an educated conversation about something, even at my level. So I love that you guys are even more expansive on that.
what do you see as the impacts of MIH on EMS as an industry? Because we've seen for a while that emergency medicine is becoming more primary care. And something you've repeatedly mentioned today is meeting patients where they're at. And I think that EMS is starting to catch up to that shift in emergency medicine. But what do you see as the biggest change that MIH is going to have or is going to affect on the EMS industry?
Well, just as you said there, I think MIH, right, is the future of EMS. I think there's always going to be 911 need, right? There's always going to be a need to respond to motor vehicle accidents and chest pain and heart attacks at home and things like that. But the ability to treat your patient where they are. Now there's some barriers that we have. I mean, we have to get paid for what we do, right? And we're currently not listed as provider with CMS, so a paramedic can't bill for their services. And so we have to fix that. And South Carolina EMS Association and Henry Lewis and those folks are working their tails off to get an EMS compensation bill through here very quickly, which is going to help, right? But the need for non-transport treatment or alternate destination treatment is good for everybody. um, the hospital has wait times or wall times, right? When you go to the wall and wait forever. The EMS system has wait times or as far as response, starting to triage calls out now and who gets an emergency response, who doesn't get emergency response, how long do they wait, things like that. And so the mobile integrated healthcare piece, the non-urgent treat in place or alternate destination is, I think, going to be key for sustainability in EMS and also healthcare systems, right? We're already making an impact in the number of people that return back to the hospital within 30 days. We're already making an impact in ED bounce backs from skilled nursing facilities. And so all of those metrics are metrics that are important to continue to prove that we're valuable. We have value, we have purpose, and we should get paid. That's yeah, but I think you see us moving more to a holistic kind of a treatment. I don't think it's a bad idea that we're starting to go back into the home and treat people where they are.
No, I agree. Because I mean, how often do 911 providers go out to address a problem that could be handled if there was the infrastructure? It could be handled at home and not have to bring that patient into the ER and start a whole process that is, not that it's the hospital's fault, but just frustrating for people who go into an overwhelmed ER, have to wait for hours when that could be handled at home. I think it'd be interesting to see the shift of burden onto the away from the 911 services too. I think that'll help. Personally, I think that would
Well, I
help a
mean,
lot.
every paramedic has run the call of my heater won't work, but it's masked in toe pain, right? And so it's the call is toe pain, and you show up and you go out there, and Miss Smith says, "Oh, my toe's been hurting for a year, and I just can't get it to feel better." And and you okay, and you're patting heads and rubbing tummies, and you're doing your thing, right? And then you say,
Yes.
"Well, no, do you want to go? Do you want to go to the hospital? Do you want to go to the ER?" And she says, "Well, Dan, while you're here, my heater doesn't work." Right. And Dan walks over to the thermostat and he says, "Oh, Miss Smith, you got to turn it on to heat. There you go. Now you're working." Right. Or my TV doesn't work. And Dan hits the input button and goes to the right input. And all of a sudden now our TV's on. We've all run those calls. We've all done that at 2, 3 o'clock in the morning. And I'm not saying that's the role of the community paramedic, but I'm saying we do that for like our PACE participants, where it's actually just going out and making sure they're comfortable, giving them a little bit of reassurance. And I said patting heads and rubbing tummies, but I mean, it kind of is. It's kind of just giving them a little bit of confidence that, you know what, it's okay. It's okay that, you took an extra vitamin C pill today. Right? It's okay that your Meals on Wheels didn't come and you had to eat 2 grilled cheese sandwiches. Like,
Mhm.
tomorrow will come and we're going to go to the clinic and all is going to be well. And, and just a little bit of encouragement, where that call traditionally would have been two paramedics or two EMS professionals standing in the home going, do you want to go to the ER or no? Right.
Mhm.
You'll
Mhm.
go, we got, I got things I got to do. Do you want to go to the ER? Do you want to go, or do you want to go, you want to stay here? Yeah. I need you to just find this. And so, why not send the community paramedic to something like that to
Mhm.
address a social determinant of health?
Well, so it's interesting you kind of bringing that up gives me kind of a train of thought with expanding the paramedic scope of practice into the community paramedic and being able to do more and have conversations with nurses and doctors and stuff. Do you think that community medicine could ever utilize EMTs, maybe more on the social side, being able to help with like the basic, breathing treatments and maybe expand their scope a little bit more as well to give not just paramedics, but also EMTs an expanding scope of practice to assist, even if it's more on the emotional side with the basics?
Well, and yes, the answer is yes. There's opportunities for EMTs, advanced EMTs. A lot of the things that we do, I say we do a lot of social work, and about 90% social work and 10% medicine. Right. So a lot of the things that we do, an EMT, an advanced EMT could do. Just educating on disease path or disease processes,
Mhm.
educating on medications, why you should take this pill at night versus in the morning. Right. There's a reason the doctor wrote it to take it at night. Here's the reason for you to take it at night. And do you understand that? Yes, I understand it. Making it easy to take medications, whether that's put them into a pill minder, or I've even had providers take Sharpies to the top of pill bottles, and one's blue, purple, green, and red, and say, Miss Smith, you take one purple and one blue in the morning and one red and one green in the afternoon, right? And so it's not even a medication. It's just take the color, right?
Yeah.
Take the red one in the
Yep.
morning when you get up. You take the red one. Uh, if that's where they're at, then that's where they're at. That's where you meet them at, right? You meet them where they're at. That could be in their home, their educational level, their experience, their medical knowledge, anything. You just meet them where they're at. If they need to have a red pill bottle, then they get a red pill bottle. If they need to have, an actual pill minder that has months and days, and you go over it with them. And it's not just you doing it for them. It's you saying, my goal is to get you to be able to do it. Right. I
Mhm.
want you to understand it enough that I don't have to come out here and do it anymore, that you can do this. And so,
Mhm.
paramedics, EMTs, advanced EMTs, anybody can do that. Right. In our program, we set it up as an ALS provider just because of our ETS program.
Yep.
Um, I don't know what EMTs and advanced EMTs look like at Prisma, but in other programs, absolutely.
I remember back, I can't remember what year this was. I want to say it was the ET3 program. It was like the alternate destination transport. Is that something that is still a thing? Is that in the cards for EMS, or is that it's specifically kind of falling out?
Right. So ET3 was stopped by the federal government several years ago,
Okay.
as a program that just didn't ever take off. Um, I have personal Luke Estes opinions about ET3. We chose a population that was very difficult for someone to be comfortable with, right? So if I'm in the home, and it was traditional Medicare patients, they had to have traditional red, white, and blue Medicare card.
Mhm.
They couldn't have any Advantage Medicare plans, nothing. It just had to be traditional red, white, and blue Medicare. Well, that population is already over the age of 65 and greater, right?
Mhm.
With all a bunch of comorbidities. And so it
Mhm.
was very hard to get somebody, a physician on the other end of the line, to agree with leaving Meemaw with generalized abdominal pain. Right?
Mhm.
Like, it was like, oh, she just kind of has abdominal pain. Well, she's also 80 and she has a history of cardiac stents, and she has, GI problems. She has diabetes, and she has, all of these things. And
Right.
so, the physician on the other end of the line was kind of like, I'm not sure I want to leave Nana
Mhm.
at home with
Yeah.
generalized abdominal pain. And so I think we had the wrong population, we being the program. The program had just the wrong population identified. And then it was also really difficult for the telehealth piece, even for someone like us at Prisma who had established telehealth procedures,
Mhm.
to get a physician to get onto the other line. That patient had to be registered through the hospital prior to talking to the physician. So they had to be a patient, then they had to get
Gotcha.
registered, and then they had to find the doctor, and then the doctor had to do their thing. And so, really, as an EMS service, I think, not speaking for our EMS service, but I think an EMS service, it was better off just taking them to the hospital. We're already 45 minutes into the call waiting on a doctor to answer the phone, and we could have been at the hospital and back in service 10 minutes ago. And so
That's
the federal government actually set that program down several years ago.
Gotcha. I knew it wasn't still. I knew that specifically wasn't still in effect, but I didn't know if there was still any kind of push for, taking, say, a 20-year-old that, a 20-year-old with belly pain or something. Hey, we can they don't have means of transportation. We can take them to a designated urgent care or something like that. We don't have to take them to a full-fledged emergency room. Um, I didn't know if there was anything like that that was still in the works to take the burden off the hospitals, or if we just kind of said we're going to suck it up and we either treat in place like y'all do with community with the MIH program, or we take them to the hospital.
Yeah, I think there's some work, and I don't want to speak for the South Carolina EMS Association, but I believe that's what they're trying to do is an alternate destination bill,
Okay.
along with that compensation bill.
So I did have a quick question before we kind of move on with the EMTs and the paramedics. What is the barrier to entry to become a community paramedicine? Because like with critical care, they like you to have like 3 years in a busy 911 service before you get certified and all that kind of stuff. So what is the barrier to entry to work, for example, for Prisma MIH?
Right. For Prisma MIH, a total year paramedic of 5 years. And we prefer at least 3 of those to be in a busy 911 service. It does help if you have a critical care credential, either through IBSC or Baltimore or wherever you get your critical care credential. And then we require within 1 year of employment, you have your IBSC CPC, so your community paramedic certification. We send you to class. We send you to the University School of Medicine in South Carolina, who does a
Mhm.
community paramedic course. We pay for that. You test within a year. And those are the only requirements: 5 years as a paramedic and um, 1 year requirement to get your CPC after your employment date, and the willingness and ability to do extra training. Right. I make that very clear when you sign or when you're interviewing with our mobile integrated health, is that, you know, just being a part of a healthcare system comes part, and both of you are aware of the healthcare side, healthcare system side of training, right? Everything that's in Learning Hub and what you have
Yes.
to do, and to be part of the healthcare system, right? But then there's also we have a fantastic training team at Prisma who hold CEP, and they have critical care CEP, and they have mandatory COG testing, and all of these things that you have to do because you still have to be an employee of the ambulance service.
Mhm.
And then, by the way, we're going to want you to do these skills like G-tube, trach, so you have to go to clinical education and get those checked off. So you have to do a couple in the hospital system so that the hospital system can check you off to do those skills, right? And so I I hate it when you hear somebody say that mobile integrated health is where paramedics go to die, right? It's not a retirement program. Um,
Mm.
we hold our own community, or we hold our own CEP. So
Mhm.
we have if you work at Prisma, you have and you're in mobile integrated health, you have mobile integrated health CP, critical care CP, and regular ambulance CEP. So plus
Not
everything
including
else
all
that
your
it can do.
online education.
Now, with you
Correct.
mentioned
Correct.
you have a lot of the silos of what you do, which I think is great, especially coming from a hospital system that is so pro EMS, and it seems like they are very focused on putting the money there where it's needed. What are you guys doing different And I don't mean this not in a negative or disparaging way at all, but what are you guys doing different than, say, comparable agencies that have MIH or CP programs?
Yeah, and it's hard. It's hard to compare because sometimes you're comparing apples to oranges, right? The community based needs of Richland County are far different than that of Oconee County, right? And so yes, we have the ability and we have the support of the healthcare system, which makes us very fortunate. And I am very fortunate and very blessed to have Prisma Health behind me, right? That is a driving force that, you know, other county EMS services don't have, right? When it came to getting our CLIA, and we're the only EMS agency in the state of South Carolina has two moderately complex CLIA licenses,
Mhm.
right? And so when it came to getting our CLIA, thank God for our lab people, right? For Sonia Evans and our lab person, people at our lab who were like, "Oh yeah, we got you. We got a book and we can run you through this and we can get you squared away," right? That's not going to happen at a county EMS service. Same thing with other ultrasounds, and all that stuff has a price tag to it, and training has a price tag to it, and what is its usefulness, and so it's kind of hard to compare because it's apples to oranges kind of. But what the Lexington County EMS CP program is doing is no different or less impactful than what Prisma Health is doing, or Calhoun County is doing, or Marion County is doing. Like they're finding what the needs of their community is and or community are, but what their needs are, and then finding ways to address those. And because they're paramedics, I bet you they're doing a darn good job of it.
Do you think that the QA/QI on, like, the 911 calls is something that can kinda help guide the stuff that the community is needing to see, like, repeat cases going back to the ER within the 72 hours to 30-day time period and stuff like that? Like, QA/QI is a big deal when it comes to guiding community paramedicine?
Yeah. So again, we have our own MIH QAQI that Scott does with Dr. Elks as far as QAQI and what we do with our patients. But I think, again, being attached to a healthcare system, I think to your question, yes, your QAQI from a 911 provider EMS system is probably going to drive what your frequent users are, where your frequent space is, what your overdose rate, where those overdoses happening, all
Okay.
of those things, right? And we
Yeah.
do part of that. But again, being part of a healthcare system, right? I have to
Yes.
worry about things like EDAC scores, like extended days of acute care, and readmission rates, and ED bounce backs, and all these things that we have metrics on that are calculated by the hospital. So the hospital has an idea of where they want to go and what they want to do, and we're
Mhm.
tasked with usually tackling one of those metrics, right? Whether that be CHF or sepsis. It's hey, we're seeing a trend in this. Where can community paramedics help us? And we said, well, this is what we can do. The answer to your question is yes. Your EMS QA/QI process can identify trends in places where you need to work. For those of us who are fortunate enough to be part of a large healthcare system, those metrics are given to us almost weekly, if not daily, and go try to do something about this, right?
What's your wish list? Like the things that you want to do with your department that you either don't have the funding for yet or are just still in the works and not anything that you can do quite yet.
Well, my wish list to my bosses are always more people, more capital, more vehicles, right? Because we can do more. We're not seeing all the referrals that are given to us, just because we're limited by manpower, right? I mean, it's just hard to see all the referrals that are given to us. There's work to be done out there. That's why we welcome at Prisma. We welcome Pickens County community paramedic. We did McLeod's community paramedic. We just had one from San Diego or Sacramento, California come. Like
Wow.
there's plenty of work to be done, and we are not gonna we're not shying away from here's some patients if you need some patients, right?
Mhm.
And so my first ask is always people, vehicles, and FTEs, capital, and equipment. That's what I need, right? Um, I understand there's barriers to those, financially and those things. The next thing that I would really like for uh, community paramedics to start doing is we're already doing adhesive suturing, right? We're already doing dermabond in the
Mhm.
skilled nursing facility. I would like to see us actually do suturing. There's a number of
That would be
times that
cool.
that we could actually just suture a small, and still within the regulations or the confines of our COGs with dermabond, right? So the hospital says, hey, okay, you have a COG for dermabond, but you can't dermabond anything clavicle and up, right? Because we probably shouldn't be messing with lacs and things on people's faces and heads, right? So suturing within a realm of clavicle up or whatever, right? I'd like to see us do some suturing. I'd like to see us use more ultrasound. There's all kinds of applications for ultrasound out there. We're primarily using it for lung sliding and IV
Mhm.
starts,
Mhm.
right? But there's so much more opportunity to use it at the bedside in these skilled nursing facilities. Again, that comes with training, that comes with credentialing, that comes with all of these things that I want or want to see us do. Just creates more work for Scott and our training department. But it's like, but I'd like to see us all do it. I think it'd be awesome to be able to do all those things. It's just understanding that the finances and the time aspect it takes to do the credentialing for these things. Um, our ultrasound wasn't quick. Well, we probably
Yeah.
2 years it took us to
Mhm.
credential
Mhm.
everybody.
Mhm. Sounds like you need more educators.
Oh, yeah. Maybe I should add that to my list. I need what do they call them? A field training? No, what do they call them over there? CFF.
CFS, yeah,
Yeah,
CFF.
CFS,
Yeah.
clinical field specialists
because
Yep.
it has to be
Yep.
different than everybody else. So got to come up with a
Right.
different name
Yep.
for it.
I need one
instead
of
of
those.
FTO.
Right. I need one of those.
Well, and I've always, and again, I can't sing the praises enough of Prisma as a whole. And I can say this because I don't work there anymore, so I don't have any invested interest in fluffing them up. You know, they do such a good job of giving money and resources to EMS, period. And I think they have a broader understanding of the continuum of care. I think that was probably the biggest thing that I have taken away over the years working with and interacting with Prisma is they've got that they've got that perspective on lock, and you've really elaborated on that very well today of we are all part of a bigger team. We're yes, we have different roles and functions within that, but it's patient centric. What's the right thing for the patient as a whole, and how can we all collectively work together to do that? So I love that. I love hearing about it, and all your people seem happy, and you seem happy, and I love it. I do.
Yeah, I'm fortunate to be able to, go around and share our program success stories, and even failures, right? So I mean, even to say, hey, these are some things that we tried that didn't work, or these are some things that, were just not really what we thought we're getting into. Um, Maybe they worked for you, but here's what we learned, right? So just going around and sharing all of those stories. MIH is one of those things where your wins are extremely big, right? When you have a win, it is, man, we've really affected somebody's life, right? We've really done some good things here, but also the lows are extremely low when you know that there's resources or things out there for a patient and they're just not really willing to take it, or they're not willing to engage in their healthcare, or you just can't get the stars to align with all of the different people that have to come together to get them the resource. That's a low, and it's a low. It's a roller coaster of emotions, and but I think to your point of just being supported, I think a lot of that comes from our leadership at EMS at Prisma, right? I mean, they're 110% on board of 911 and EMS. They really advocate for, but also participate in the local EMS systems. So, I think that we just get a lot of good, what do I want to say, a lot of good attention. The spotlight's always on us, because they do a fantastic job of just being engaged with the hospital and the community.
With Prisma Community Paramedicine, y'all are covering a lot of locations in pretty much all the counties in the upstate, if I remember correctly, right?
Yeah, we got about 13 counties that we're in.
How, like, especially for local, like, EMS, agencies and such, if they know that there's whether it's a SNF facility or a certain population of need, how do they reach out to get a hold of you to let you know that there is a certain need in a certain area?
So they can we get a lot of referrals via email. So other county agencies, their providers are contacting us via email and saying, hey, if you could just help this person, that would be great. If you could just go see this person, and we always try to respond back, hey, we'll put them on the list. Understand that the program's a voluntary program, right?
Yeah.
So we'll reach out, we'll make a contact, we'll say, hey, this is what we do. Uh, Either they accept or they don't accept, but I always try to tell my folks to get back to that original referring person and say it didn't work out, or we're going to try to do this, or we're scheduled for next Tuesday, or whatever. Because if it didn't work out, then next time you see them, put the bug in the ear again that mobile integrated health or community paramedics are out there. So referrals are good. You can get a hold of us. I can give you some contact information that you can get a hold of us for. But we can't take everything that comes in,
Yeah.
but we'll take a peek at it, and then also realize that a lot of Prisma patients are in all these other counties, and so
Mhm.
they may already have a Prisma referral from case management or the
Yes.
physician on to be in the program. And so in that case, we just let you know that they're already on the list, and
Mhm.
we're working the list.
Now, do the referrals have to come in through the hospital or an established healthcare facility, or do you have individual agencies, EMS agencies, reaching out to you as well?
Yeah, we have individual agencies reaching out to us just via email, and saying, hey, can you help us with this, or we took this patient home, or we've been going to this patient's house the last 3 times, and really all they need is just blank, right? Because every EMS professional that's in a truck going to any call is kind of sort of a community paramedic, right? They see needs, they see the needs, and they see the I wish I some say I wish I could help, right? I wish I could do more. That's how you get involved in community paramedicine, is you're the paramedic that's going on 911 calls going, man, we could do so much better. Uh, but we get them from other agencies. We get them from primary care doctors. We get them from, family members of people that we've seen before, right? Oh, this paramedic came out and saw my mom. Now my aunt is having, knee surgery, and she's immobile for 3 or 4 months. And we're worried about transportation or getting her medications to her, or, food, all those things. And so, yeah, they come a number for different ways, but primarily from the hospital, it is patient referral into our work queue, and then our staff works our work queue down to disseminate that to the geographical location in which the community paramedic is, so the patient.
So in theory, so like for someone like me who works 911 out in the upstate in general, if I'm out at a patient's house that I've been to multiple times before, and I'm not just trying to pass the you know pass the burden to somebody else, but legitimately saying, hey, there's a legitimate need here. Is that the kind of thing where I can directly reach out to you, or do you
Absolutely.
guys prefer it filtered through administration in some way?
No, 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 no. We take it from all of them come from providers. Almost, well, I don't want to say all of them. Majority of them come from providers. Sometimes we get an EMS director that'll reach out, but most of the time it's actual providers in the streets saying, "Hey, this is what we're seeing."
Now, from a HIPAA standpoint, how, because obviously if I'm talking to you directly in a clinical context, I would assume that HIPAA would cover that conversation. But as far as an actual proper referral and transmitting that information to you guys safely and in a HIPAA compliant way, how does that work?
That's why the majority of them come from our work queue out of Epic, right? Because all of that's HIPAA compliant. If you're gonna come to me with a need, we've done that via email before. Just most agencies have a confidential tag to their email, right? So like if you put confidential in the subject line, it makes it confidential, and so send a confidential tag to it, and really all I need is a name and date of birth, and we can find that patient if they're a patient of ours, and let you know where they are, kind of in the process of being worked by MIH.
Do you have anything
No,
specific to add on?
no, my brain's exploding. I'm thinking of all these things. Just it's just
There may be a professional conversation that happens independently from all of this, so
very much so.
be ready.
Yeah. I welcome it. Yeah, there's always there's needs everywhere, and you don't really have to be a community paramedic to solve some needs, right? I mean, just you got to have a little bit of knowledge of what the resources are.
Well, and I think that's the biggest issue is most counties know that Prisma has an MIH program, but a lot of people don't know what that entails. They know that it's a niche, it's there, you have it, but a lot of what we've talked about, the education, the opportunity, that anybody can refer, even if you don't work for Prisma, there's a lot of this that general providers don't know.
Right. Yeah. And even, I mean, we just did CEP, September for our folks. A lot of our folks, I mean, we have 400 something folks. A lot of our folks didn't know that MIH was that entailed.
Mhm.
Right. They're like, oh, we
Mhm.
didn't know that that MIH did that. I'm like, yeah, we've been doing it for years, you
Yep.
know?
So I guess to kind of wrap up, we have a bit of a tradition with whenever we have guests of a more personal question. Obviously, you've been in EMS for a while. If you could dial back in time to 18-year-old Luke,
Mm.
what would you tell that version of you? The things you've learned, the insights you've had, what would you pass on to that version of you?
Yeah, well, hopefully I would be one of those people that I already had standing beside me, supporting me. Those Alan Beards, those Marty Paynes, those the guys that were just coming up through EMS in the 70s, and we're saying, hey, do this, do that, doing just what I'm doing now, right? So I'm standing next to my 18-year-old self, and I say, hey, just keep pushing, keep learning, and don't get so worked up or upset about the little things that you can't change, because the little things that you can't change really don't matter. And I still struggle with that as 40-year-old Luke, right? Is getting told something that immediately sends me into the, well, we can't do that, we don't have enough staff mode, right? When we're just talking about it, we're throwing it out there, we're throwing the idea out there, and you know what? Every time I've said we can't do that, we just don't have the staff, our team pulls it off. And they just get it done. And whether that's a double-edged sword or not, I don't know. But we're good at taking tasks, and I guess probably with EMS complaining about the tasks we're given, but then just going and doing it and getting it done and doing a heck of a job, and being that extraordinary, compassionate, excellent, clinically excellent care. Right. I mean, that's what is on all of that's my hashtags. So trying to keep MIH strong.
Well, Luke, we really appreciate your time. Really, really do. It's always good to see you. And hopefully we can continue to put the good word out for this. And you're doing great things, and I'm really excited to see what y'all accomplish in the near future.
Yeah, the team kills it, man. I go to meetings and send emails. So that's what I
Leadership's
do.
important, though. Good leadership
Yeah.
is important.
Very much so. I think it would be very cool to see if Prisma is able to expand into the EMT and advanced EMT involvement in MIH. I think that is going to help not only with retention, but it just meeting patients where they're at. It gives everybody a different opportunity than just running the general 911 calls.
If you enjoyed this episode, be sure to follow us on YouTube at paramedicaf, or you can subscribe on Apple Podcasts and Spotify at the Paramedic AF Show. You can catch up on the Daily Debrief, kind of a sub-show within the Paramedic AF Show, or you can watch our full-length episodes, including interviews and discussions on leadership, culture, personal wellness, mental health, everything related to daily life in EMS. Make sure you hit like and subscribe.